Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for pulmonary medicine and surgery. There are some changes you will need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. So take a deep breath, relax, and let's get started. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site, and use exact dates when appropriate. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, write acute on chronic respiratory failure instead of respiratory failure. Use due to or secondary to indicate cause and effect and to record all conditions the patient may have, such as acute systolic heart failure due to or secondary to hypertension. Think about the most current terminology to describe a condition or different aspects of the disease. For example, mild, intermittent, or mild, moderate, or severe persistent asthma. Precisely designate anatomical sites such as bronchus of the right upper lobe. Use exact dates when appropriate. For example, when a patient is admitted for acute myocardial infarction and the patient previously had a recent MI, document the exact date of the recent MI. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care. Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. Classification of asthma is an example of the use of updated terminology in ICD-10. Asthma is now classified as mild, intermittent, or mild, moderate, or severe persistent. Documentation of acuity remains unchanged from ICD-9. You should continue to document the presence of an acute exacerbation or status asthmaticus. For example, a diagnosis of severe persistent asthma with acute exacerbation is classified to J45.51. Classification of pneumonia and pneumonitis is very similar to ICD-9. It continues to be important for you to document the type of pneumonia, for example, aspiration pneumonia, and the organism, such as Klebsiella, when known or suspected. Remember, a coder cannot base code assignment on a sputum culture or cytology report. You must document the organism in your note indicating a cause and effect relationship, such as Klebsiella pneumonia or pneumonia secondary to or due to Klebsiella. ICD-10 provides combination codes to capture acute bronchitis due to 8 different organisms. Document the specific organism causing the acute bronchitis when known or suspected by using due to or secondary to indicate cause and effect. Note that you must document the word acute when your intended diagnosis is in fact acute bronchitis. Otherwise, a diagnosis of bronchitis is assigned to a code describing bronchitis not specified as acute or chronic. Chronic bronchitis has its own classification. If you can further specify the type of chronic bronchitis, such as simple, mucopurulent, or both, a unique code describing the specific type will be reported. ICD-10 differentiates COPD with acute lower respiratory tract infection from acute exacerbation of COPD without infection. When an infection is present, document the specific infection and organism when known or suspected. When respiratory failure is present, it should be specified as acute, acute on chronic, or chronic. Dependence on supplemental oxygen should also be indicated when applicable. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, further specificity is provided in ICD-10 for the type of tobacco product dependence, as cigarettes, chewing tobacco, or other, for example, cigars, so this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. ICD-10 has greater specificity for anatomical site and usually requires documentation of laterality for paired organs. Be sure your documentation is as specific as possible when identifying anatomic site. Unchanged from ICD-9 is the classification of malignancies as primary or secondary, which is a particularly problematic area of documentation for coders. Often, primary or secondary is not specified, and in the case of secondary malignancies, whether the primary site is still present. A statement of history of can be ambiguous and may prompt a query. For example, appropriate documentation of a lung malignancy would be metastatic cancer to left upper lobe of lung from left breast. Patient had left mastectomy 1 year ago. This documentation clearly identifies the primary and secondary sites and states the primary site is no longer present, all of which are factors considered in code assignment. Most types of emphysema were grouped into a single ICD-9 code. What's new in ICD-10? Separate codes are provided for specific types of emphysema. When you document the specific type of emphysema, such as unilateral, panlobular, or centrilobular, a unique ICD-10 code for that condition can be reported. ICD-9 did not differentiate between a diagnosis of respiratory failure and acute respiratory failure. The good news is that ICD-10 does. When appropriate, you should document respiratory failure as acute, chronic, or acute on chronic. Additionally, also specify if hypoxia or hypercapnia or both is associated with the respiratory failure. Remember, coders cannot interpret the results of tests such as arterial blood gases. They must rely on your documentation. At times, we see respiratory insufficiency and respiratory distress used interchangeably with respiratory failure. Respiratory insufficiency and distress are signs and symptoms of an underlying condition and are coded differently from respiratory failure in ICD-10. Be clear on your intended diagnosis. Severity of illness will not be reported accurately if you use one term when you mean another. Additionally, document the cause or etiology of respiratory failure, such as due to COPD, surgery, or trauma. When pulmonary insufficiency is due to surgery, documentation should describe a cause and effect relationship, and it should be further described as acute or chronic. For example, acute pulmonary insufficiency due to surgery 2 days ago. FYI, one of the differences in ICD-10 is that pulmonary insufficiency due to surgery will be classified as either due to thoracic or non-thoracic surgery. Other causes of pulmonary insufficiency, such as chest trauma or hemorrhagic shock, when known or suspected, should also be documented in terms of cause and effect. What's new here? ICD-10 has a new combination code to capture the patient who has a pulmonary embolism with acute cor pulmonale. The takeaway here is the documentation of cor pulmonale and whether it is acute or chronic. What stays the same is that you still need to document the type of pulmonary embolism, such as septic or saddle, and whether the pulmonary embolism is acute, chronic, or healed or old. History of can be interpreted to mean the patient has had the condition for a while, such as in history of hypertension, or interpreted to mean the patient no longer has the condition. Documentation of chronic pulmonary embolism versus healed or old PE makes a clear distinction and assures that the severity of illness of your patient is reported accurately. Severity of illness is increased when a patient has a chronic pulmonary embolism, but there is no impact on the severity of illness when the patient has a personal history of pulmonary embolism. Note that documentation of healed or old PE results in the reporting of a code for personal history of pulmonary embolism. ICD-10 terminology describing congestive heart failure remains essentially unchanged from ICD-9. However, there is currently an opportunity for improvement in documenting this diagnosis. To provide an accurate picture of the patient's severity of illness and risk of mortality, you should specify whether the patient's congestive heart failure is acute, chronic, acute on chronic, and whether it is systolic, diastolic, or a combination of both. Additionally, you should document the cause or etiology of the congestive heart failure when known or suspected. An example of excellent documentation would be acute systolic heart failure due to possible or suspected alcoholic cardiomyopathy. ICD-9 provided a single code for cardiac arrest. ICD-10 provides the ability to report the cause of the cardiac arrest when known or suspected as due to an underlying cardiac condition or other condition. Your documentation should indicate a cause and effect relationship by using words such as due to or secondary to. The look and feel for codes describing diabetes have changed, but the level of detail describing the disease remains mostly the same. Therefore, your documentation doesn't need to change as long as you are currently documenting the type of diabetes as type 1 or type 2 and any associated complications. For example, diabetic peripheral angiopathy, diabetic autonomic neuropathy, or diabetic foot ulcer. The good news is that ICD-10 uses single combination codes to describe the disease. ICD-9 usually required multiple codes. Take, for example, the diagnosis of type 2 diabetes with diabetic peripheral angiopathy with gangrene. This diagnosis required 3 codes in ICD-9, but in ICD-10, 1 code reports everything. An additional code is assigned when you describe the patient's diabetes as poorly controlled or out of control. Malnutrition is an underdocumented condition in the elderly. However, it is also an important indicator of your patient's severity of illness and an important influence on performance metrics such as readmission rates, length of stay, and quality outcomes. If your patient has malnutrition, you should document the clinical picture, the type, such as protein calorie or protein energy malnutrition, and the stage or degree. For example, mild, moderate, or severe, or first, second, and third degree. Your notes should include clinical findings such as patient with terminal cancer, 20-pound weight loss, and cachexia, and any supporting labs such as low albumin. As physicians are increasingly held accountable for patient outcomes, a huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, and no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies a situation in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient undergoing outpatient treatment for bronchitis is admitted with pneumonia. After investigation, it was found that the patient did not take the antibiotic prescribed for bronchitis because antibiotics upset her stomach. Patient has age-related dementia and forgot to take her Cipro as prescribed, or patient could not afford to pay for the antibiotic prescription. In ICD-9, codes for complications did not identify when the complication occurred, the body system affected, or type of surgery performed. ICD-10 codes do. In order to code a complication, the coder must know whether the complication occurred intraoperatively or postoperatively, so include these details in your notes when it is not readily apparent. Additional elements needed for code assignment, which the coder should be able to determine from the record, are body system of organ affected and body system on which the procedure was performed. For example, as seen here, post-procedural tension pneumothorax due to perforation of lung during bronchoscopy with biopsy is assigned to code J95.811. ICD-10 PCS has specific definitions for these procedures. A code for excision is used only when a portion or part of an organ or body part is taken, for example, a wedge resection of the right lower lobe of the lung. Resection is taking all of a body part, such as a right pneumonectomy. Differentiating between an excision and a resection can be problematic for the coder when your documentation is not clearly distinguished between the two. Take, for example, the surgical removal of lymph nodes. Resection is assigned when an entire lymphatic chain is removed. Excision is assigned when several lymph nodes are removed, but not the entire chain. So document precisely what or how much of an organ or body part is removed. You don't have to use the words excision and resection according to coding definitions. The coder will apply the definitions based on your documentation of what and how much was surgically removed. Documentation of excision of tissue for biopsy requires specific site and laterality. Here you see the table the coder will use to construct the code for biopsy of the respiratory system. Of particular interest is the column on the left labeled body part, which lists all sites of the respiratory system from which the coder must choose. Note, for example, that the coder must choose right main bronchus versus right upper lobe bronchus versus right upper lung lobe. Therefore, it is important to precisely identify the laterality and anatomical site of the biopsy. For example, a biopsy of the left upper lobe bronchus via bronchoscopy is coded as 0BB88ZX. Excisional and non-excisional debridements are coded differently. Your documentation should clearly state either excisional or non-excisional. Excisional debridement involves surgical removal or cutting away of tissue. This is different from a procedure that is non-excisional or mechanical debridement, and which may simply involve brushing, scrubbing, and/or washing. In the case of an excisional debridement, your documentation should state the depth of the debridement or the deepest point from which the tissue was debrided. Was your procedure limited to the skin only, or was subcutaneous tissue also debrided? A single code is assigned based on the deepest layer debrided. Each tissue layer results in a different code. ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.